Welcome to the webinar, Understanding RSV, Influenza, and COVID-19, Preparing for the Fall, developed by the Gerontological Society of America and supported by Johnson & Johnson Health Systems. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live session. We will be accepting questions through the questions feature accessible on the right-hand side of your screen. My name is Elizabeth Subcheck, your moderator for today's program. I'm the director of the National Adult Vaccination Program at GSA. Our speakers and I would like to welcome you. Dr. Robin Jump is at Case Western Reserve University and the Louis Stokes Cleveland VA Medical Center. Dr. Lindsay Kim is at the Centers for Disease Control and Prevention. Dr. Kip Talbot unfortunately had a last-minute family emergency and sends her apologies for not being with us today. Dr. Jump and Dr. Kim will be taking over the questions that she had originally intended to answer. We're all pleased to be a part of this important program. In our session today, I will ask speakers about aspects of COVID-19, influenza, and RSV in older adults. We'll hear about challenges with diagnosis and practical strategies for keeping older adults healthy this fall. We hope that you leave today's session with increased knowledge and encourage you to share what you have learned with colleagues. Without further ado, let's dive right into the first question for Dr. Kim. Can you do a little baseline setting and tell us what RSV is and why it's so important?
Hi. Thanks so much first to Elizabeth and GSA for inviting me to speak to you all today, and thank you all for joining us on this important seminar. So I'm going to start with just an overview, as Elizabeth had asked, about what is RSV. So RSV is respiratory syncytial virus. It is an enveloped RNA virus. It circulates seasonally, and in the US, the circulation period is actually slightly longer compared to influenza or flu. But it generally does overlap, and we see RSV circulating generally between October through March to early April. This does vary across the U.S. With different geographic regions having different seasonal periods. Humans are the only source of transmission of RSV, and it's spread by direct or close contact via large droplets or fomites on objects and surfaces. We also know that most people were infected with RSV as infants or young children, but repeat infections can happen in older adults. And most often it is an upper respiratory tract illness. So it can have nasal congestion, cough, shortness of breath. But symptoms are often more severe than the common cold with less fever compared to flu. And particularly in older adults that don't always have the ability to mount fever, we don't see it very often in RSV infections in older adults. Also, lower respiratory tract illnesses can also occur. This is particularly common among immunocompromised persons, those with underlying heart and lung conditions, and also older adults, of which we're talking about today. And the complications of RSV can manifest as pneumonia, asthma, chronic obstructive pulmonary disease, or COPD exacerbations, as well as congestive heart failure. In some case series, we do see mortality rates as high as 50% among immunocompromised adults. So we do know that RSV is severe and it can cause severe illness. RSV can be detected in 3 to 7% of healthy older adults, and that was defined in a study as those without any pre-existing chronic lung or heart disease. And then of those that had chronic lung or heart disease, we could find RSV in 4 to 10% of those adults. So it's super important, it's very important for patients, healthcare providers, and other persons who work with older adults to think about RSV, because it can cause severe disease. It can cause severe outcomes in patients, including hospitalization and death. So we just cannot forget to think about RSV. We need to know how to recognize it, diagnose it, and treat it. And although there are no vaccines or treatments at this time, there are many in clinical development. So it does give us hope for the future for RSV treatment.
Thanks so much, Dr. Kim. Is there anything else that you'd like to tell us about morbidity, mortality, and hospitalization of RSV in older adults?
Sure. So it's interesting to note that RSV infections in adults were first recognized as a result of outbreaks in long-term healthcare facilities in the 1970s. And most often I get a lot of questions about, well, why should I care about RSV? You know, isn't that a pediatric disease? Does not only affect children? And the burden is quite high in kids. It's true. Globally in the US, we see a lot of children, a lot of infants being hospitalized with RSV, but we also see lots of older adults being hospitalized and having severe outcomes. And so there was a study done in Rochester that found that RSV infection can cause up to approximately 180,000 hospitalizations and 14,000 deaths each year in adults 65 years and older. So those are some staggering numbers. I mean, that's a lot of older adults being affected and having severe outcomes. And those are just overall numbers. But if we look at studies of rates, we find the following. We find that average annual RSV hospitalization rate was about 15 per 10,000 persons aged 50 years and older. And that study, that was a similar rate of hospitalizations compared to influenza during that respiratory season. So we do see RSV and flu, depending on the season, they can cause similar rates of hospitalization among older adults. We also know that approximately 150 outpatient clinic visits occur due to RSV per 10,000 persons in adults 50 years and older. So it's definitely something that makes an older adult go to their provider and say, hey, what's going on? And we do see that is the incidence of seeing, you know, your primary care physician or an outpatient clinic visit, that incidence rate increases with age, with the 70 plus year age group having about 200 outpatient clinic visits per 10,000 adults due to RSV. And then lastly, another study just specifically knowing that older adults are at risk, but even within older adults, the higher risk groups are those that I had mentioned before with cardiopulmonary pre-existing conditions. So among that high risk group of adults with 65 years and older with this chronic lung disease, there was a study that found that RSV caused about 180 hospitalizations per 10,000 persons and about 50 deaths per those 10,000 persons. So again, these are some numbers that are, you know, maybe not as high as what we see in flu, but it's still a lot of illness that's out there. So taking all these numbers and all these studies into account, we know that RSV can cause disease, it can cause severe illness, it can cause poor outcomes in older adults. So it's super important, it's very important to think about RSV, particularly during this upcoming respiratory season and other respiratory seasons following.
Thank you for that information. You mentioned that we often hear about RSV in infants, but maybe less so in older adults. And I'm wondering if you can tell us a little bit about what kind of challenges there are with diagnosing RSV in older adults.
Sure. So the main challenge really is recognizing RSV as a possibility in causing respiratory illness in older adults. There was one survey of primary care physicians that we published at CDC with other colleagues in Colorado, looking at primary care physicians' knowledge of RSV. At almost 60% said they rarely considered RSV as a cause of illness in their patients that were 50 years and older. And they don't test for RSV due to the lack of treatment, that they, you know, there was nothing coming down the line that they felt like, even if I know it's RSV, who cares? But it is essential to figure out what it is and see if we can, you know, what the pathogen is, what the etiology of that illness is. So aside from educating persons who care for older adults about RSV, if we're talking about diagnosis in older adults, there are very good laboratory tests to detect RSV. We also have tests that can diagnose RSV and flu at the same time, as well as others that test for many other respiratory pathogens all at once and simultaneously. And these are now widely available to practitioners. The challenge that we have, particularly in older adults, about diagnosing RSV is one, again, like I said, it's just recognizing the possibility that RSV might be causing the disease. But number two is that older adults usually have a much smaller viral load. And viral load is, you know, to put it in simple terms, it's a number of virus particles in the nose or throat, which is where we swab for RSV, than compared to children. So children, they have a lot of snot. they have a lot of boogers, and there's just a lot of viral load there. So even if you swab them, maybe not close to when they got their symptoms, but even further along in their illness, we have a high probability that we're going to capture some of those viral particles and detect RSV. However, in older adults, the baseline, the amount that starts off in their nose or their oropharynx is actually lower than children. So the viral load is lower, and so it can be more difficult to diagnose it right off the bat. Also, because the viral load decreases after the initial infection or symptom onset. If an adult, and adults tend to do this, they battle symptoms for several days, and then they go and seek care if they get worse. And then potentially their provider might test for RSV, but it could be many days after the initial infection. And if that's so, then RSV may not even be detected at all because the viral load is so low.
Again, thank you for that great information. I think what we've all been talking about and thinking about is this co-circulation during the fall season. So can you share a little bit about how RSV hospitalization burden compares to flu and COVID-19 hospitalization burdens?
Sure, thanks for that question. And again, in my work at CDC, I specifically look at hospitalization burden of RSV as well as COVID-19. What we know about from our surveillance platforms at CDC for RSV and flu is that the hospitalization burden among older adults can be comparable. It can be very similar during some of the respiratory seasons in the US. Again, this respiratory season defined as between kind of September, October through March through April. So depending on the year, we can see that RSV hospitalization and influenza hospitalization rates can be very similar. But in other years, we can see that flu can be appreciably higher than RSV among older adults. And even in some other seasons, we see that RSV can be higher than flu. So flu and RSV, while similar, they are different pathogens, and we had to treat them as such. And then if we're looking specifically about COVID-19 and the rates of hospitalization among older adults, what we do see is that the cumulative rates of hospitalization among adults 50 to 64 years and 65 years and older is higher than the cumulative rates of hospitalization for RSV and flu. Specifically, I can comment on flu in saying that the overall cumulative hospitalization rates for COVID-19 are higher than the cumulative end of the season hospitalization rates for influenza over each of the previous 5 influenza seasons. So there is quite a burden of COVID-19 associated hospitalizations. But again, we cannot forget the burden that already existed related to RSV and flu.
Great. This one will start with you and then move to Robin. So when we think about the fall in respiratory disease, it seems like there's a strong likelihood that flu, RSV, and this year COVID-19 will all be circulating at the same time. And so I'm wondering if you can both speak about the challenges that this will present to those who work with older adults, and really, how will we be able to tell the difference? Will we be able to tell the difference? Lindsay, if you want to start, and then we'll jump to Robin.
Sure, great. Thanks. Sorry about that. I was on mute. I think that's a great question that Elizabeth is brought up, and I think many people are thinking that as this fall season and the respiratory season starts up very soon. One of the challenges that we have about respiratory viruses overall, not just for COVID-19, is just that older adults, again, they can present atypically with flu and RSV. So it's even harder now. We have a third pathogen, SARS-CoV-2, that's now out there causing COVID-19. And while we do have some data and studies out there telling us what are common symptom presentations, that is still something that we're still studying. That's still something that we're learning. And so, it will be a particular challenge for this season. There's a lot that is unknown about that clinical presentation. So we already have uncertainty and atypical presentations for flu and RSV in older adults, and now we also have COVID. But I think that brings up, the biggest thing here is that, any type of respiratory symptom in an adult, particularly this season, any shortness of breath, any concerning symptom in an older adult, or any adult for that matter, it needs to be taken seriously. And, adults and patients should be encouraged to talk to their primary care providers and get their assistance in determining what the next steps are should they be having concerning symptoms. Again, adults and particularly older adults are very susceptible to these viruses. So it's incredibly important for them to seek medical advice and care as determined by their provider.
Dr. Jump, would you like to add in here?
Sure. Let me start off by saying thanks for inviting me to be part of this presentation, and also to GSA and to Dr. Kim for her remarkable and in-depth knowledge about RSV. I'm amazed at how you're able to just kind of rattle those studies and those numbers right off. That's phenomenal. So I agree with everything that you've had to say, and I don't think that we're going to really be able to differentiate clinically between influenza and RSV and COVID-19. We certainly know that we can't use symptoms to differentiate between influenza and RSV, and then it's going to be the same with COVID as well. So I think the best thing that we can do for both our community and our nursing home dwelling older adults is to test them, and we need to do COVID testing and influenza testing and RSV testing. And thankfully, there are a number of platforms now that allow for all three of those to happen. And depending on the circumstances, it might be worthwhile to consider doing like stepped testing or tier testing. And what I'm thinking about here specifically are people that are living in long-term care or assisted living environments where there may be a known outbreak or a known high community burden of influenza or COVID-19 at that point in time. And if that's the case, and if you don't have access to multiplex testing, so you can't test for all three viruses at once, it might be worthwhile to start off by doing, say, influenza, if you know that influenza is currently having an outbreak in that facility or that region. And I'll stop there.
Thank you. I think that leads nicely into the next question, which is where you have a wealth of information to share and knowledge, which is, what are some things that we can do to keep older adults healthy when it comes to so many respiratory viruses circulating, whether it be flu or COVID or RSV? How can we keep older adults healthy?
Sure. So I think that we're inundated with how to do this at this point, which is both good and bad. Good that we had the knowledge, bad for the circumstances. As everybody knows, washing your hands are the top three things that we can all do to help prevent disease transmission. And this is because by washing our hands, we're washing off the fomites that we pick up on our hands and then touch our face with and then rub into our eyes or our nose or into our mouth. And that's often how infection happens. The other thing that we can all do in the community is to wear masks, which we're doing for the prevention of COVID-19 transmission, as well as other respiratory etiquette measures, and that includes covering our coughs and sneezes and doing those into our elbows rather than into our hands, and just trying to minimize the possibility of spread. What we're finding in the long-term care setting with the regular implementation of masks as well as face shields is that we're not seeing a lot of, at this point, of transmission of COVID-19 from staff members to residents. And this is anecdotal information, but this seems to be patterns that I'm seeing emerging across nursing homes in general. In the very initial outbreaks that we had in the country before we knew about COVID had been introduced, there was staff to resident and resident staff transmission. But at this point, we're not seeing that. While we are seeing staff pick up the respiratory viruses is outside of patient or resident care activities. So when they're off duty, or perhaps when they're taking a break and are taking their masks off to eat lunch and aren't practicing social distancing. So that's another big thing that we can all do, is maintain our social distancing, both out in public and also when we're at work, and also to be cognizant of what we're doing with our hands, with our arms, with our bodies. And so, for example, leaning on a counter may get our forearms covered in fomites. if someone had recently been there before. So trying to be cognizant of that, and it's a lot. This is, I think that we're all entering the fatigue state of trying to be vigilant about COVID. So a way that we can work on this together is to adopt an attitude of, I've got your back. I'm here to help you. So when I see someone that, when their mask is not correctly positioned, I let them know nicely, hey, let's make sure that gets up over your nose. When I see people in the hospital that, where I work, we have PAPRs, and I forget what PAPR stands for, but basically it looks like a bike helmet with a face shield and then a plastic bag that comes over the face shield and up under our chins. And it's circulated air coming in, and so we don't have to wear a mask because it's a self-contained fresh air unit. And every now and again, I'll see someone that maybe the plastic part of it isn't correctly applied, and I just tell them, you need to make sure that gets up around, under your chin, and that your hair is pulled back out. And people appreciate that when it's given with a tone of, I'm here to help you, I want to protect you, I want to keep us all safe. And that's something that we can all do. We know that shaming doesn't work, and we know that encouraging and expressing gratitude for good behavior as well as modeling good behavior helps a lot. Thank you.
Thank you. A lot of great gems are in there. This is a period where respiratory illness in older adults has been at the forefront of a lot of people's minds the last few months, but there do still exist gaps in understanding. And so I'm wondering, we'll start with you, Dr. Jump, what you think is a gap in understanding or an opportunity to do more research in respiratory illness in older adults. So like I said, we'll start with Dr. Jump, and then Dr. Kim, we'd like to hear from you too.
Sure, thank you. And I should, before we get into the gaps and knowledge question, I wanted to suggest also that for in all healthcare settings, especially with COVID-19, in addition to hand hygiene and masks and face shields, we also need to be wearing gowns when we're interacting with our patients and our residents, and to be changing PPE appropriately in between patients or residents, whoever it is that we're caring for, so that I think that these have been well versed, or the idea of PPE and how to use it has been certainly put out there in the public. And taking it off is also important, and taking it off properly so we don't contaminate ourselves, and doing hand hygiene practices after we doff our PPE. So for gaps, gosh, there's a lot. One of the things that Dr. Kim talked about earlier was the differences in older adults and children in terms of the amount of snot that they produce. So we have a number of studies that are looking at sample collection for what's the best way to get a good respiratory sample from an older adult. We know that nasopharyngeal swabs are accurate, but they're also really uncomfortable to do. And especially for someone who is getting repeated testing, like they might be in a nursing home where people are getting tested on a regular basis, like every week. And also for people that have dementia and where they might be combative over having someone, stick something painful in their nose. These are difficult things to keep on doing. So one kind of pragmatic area that I think we should put our resources into is to figure out what's a reasonable way to get good testing. I'm anxious to see what we learn more about with antigen testing for COVID-19, because that is an interior nares sample, and how that compares to some of the samples that we've had to collect for influenza and RSV. Is it possible for us to use a anterior nares or even oral pharynx or tongue swab for some of our residents and some of our older adult patients to get a decent amount of sample? And these are challenges because as Dr. Kim pointed out earlier, there's the viral load for RSV is less than what we get in younger adults and in children. Other areas, of course, for research are an RSV vaccine. And as Dr. Kim said, those are under development. And I think that there's some going into clinical trials, if not already. one of the questions that we'll need to answer once we have a working vaccine is, how do we co-administer that along with influenza and then along with the COVID-19 vaccine? So those are going to be some additional challenges. Do we have to worry about the kind of interfering immune responses? We know that giving, for example, the pneumococcal vaccines and influenza together works just fine. And I hope that we'll find some evidence or have some evidence to show that that's true for RSV and COVID-19 vaccines too. And I'll stop there and give Dr. Kim a chance to jump in.
Sure, thank Dr. Jump. Coming from the public health perspective, I think some of the things that we are looking to learn more about RSV and other respiratory viruses, including COVID-19, are what are the short-term and long-term consequences of those infections and the hospitalization? So what happens to an older adult after being hospitalized with RSV or COVID-19 or flu? I think flu is done. They do have studies that have already documented these impacts. But for RSV, it's something that we know is an epidemiologic gap or a research gap that we haven't really characterized very well. And for COVID-19, those studies are underway. So the questions are, do older adults get more frail? Can they do all the activities of daily living that they were doing prior to the infection and or being hospitalized? So that's one kind of gap that we have and an opportunity to do more research. Other things, again, I conduct hospitalization surveillance, so a lot of my answers are about surveillance, but really just documenting the burden of disease well, documenting what are the rates of hospitalization, what are the rates of outpatient clinical visits due to RSV, due to COVID-19, what are those, and can we, then can we compare them, and then can we look and see, what are the differences between those two pathogens as well as other pathogens that are circulating. We can't forget that although we're talking about flu and RSV and COVID-19, there's many more pathogens out there, particularly during the respiratory viral season, which is starting, any minute now. Human metapneumovirus, adenovirus, all of those viruses also cause illness in older adults. We can't forget that. So these platforms, these surveillance platforms that we have at CDC, trying to figure out how to document that burden among many other respiratory viruses and not just one by itself. Specifically, one of our questions is, what are the rates of mortality on a population level? Can we actually put a rate on that? So how many deaths can we say are associated with RSV? We can't probably say that that RSV might have caused a death. It's very hard for us to say and attribute RSV as a cause of death with the data that we get. We can say it's associated if someone had an RSV positive test and then maybe died within 14 days or so. But, that's a gap, how many people actually die due to RSV. And also, obviously, COVID-19 and flu. These are all questions, I think, that are applicable to all the respiratory viruses. So what is that? In-hospital mortality rate? What about community-associated deaths? There are many deaths that occur in the community, and they might be attributed to a respiratory virus, and we just don't know what those viruses are. So how do we learn about those? I think Dr. Jump got to this about correlates of protection. There are vaccines, and that gives us hope. But, how do we make sure those vaccines are working? How do we know that the vaccine is actually stimulating the immune response the way it should be to actually impart protection for someone who gets a vaccine? So those are studies, a bit more, immunity studies that are happening, but those are very important. And again, when vaccine happens, it's not just stopping surveillance. We're going to have to continue so that we can see, what is that impact of a vaccine or even an antiviral? What is the impact of the vaccine at a population level? What are the rates of hospitalization prior to vaccine introduction? What happens to the rates when they go down? Also questions of herd immunity. So if a vaccine is coming out for RSV in older adults, does that impart herd immunity? Does that somehow protect indirectly children? What are their rates then? Does it go down? And so these are things that we seek to look at CDC through our surveillance platforms and to demonstrate that vaccine will hopefully have an impact to the U.S. population. And so, strong surveillance, is really important to ensure that we can show an impact of these vaccines, just like the way we did for pneumococcal vaccine with PCV13 and PCV7.
Thank you. There are a lot of opportunities for us to increase our understanding of a number of issues. I think recognizing that there are a number of unknowns and recognizing that that does create some anxiety, especially for this fall. I'm wondering if you could help us end on sort of a more positive note. And I'm wondering what you are most optimistic about related to our collective understanding of and management of RSV, flu, and COVID-19 in older adults over the coming year. Dr. Jump, would you like to start us off with that?
Sure. I'm especially inspired by two things. One is the way in which we've seen infection prevention and control efforts in nursing homes ramp up and become so effective. And this has been, of course, the staff bearing the brunt of this, having to start working in gowns and gloves with everybody, and the face shields and the mask, which is not something that is typical for long-term care because it's supposed to be a home-like environment, and I don't wear PPE in my home. It's been amazing to see those efforts, and it's also been joined by the administrators, by the physician and other medical staff, as well as by the residents and their families. And it's been especially hard for the residents and their family members who haven't been able to visit as much as they want or with the freedom that they used to be able to. And I feel like people have done a great job of understanding and adjusting, and we need to keep encouraging their patients and recognizing that we're all doing the best that we can. The second thing that I'm so inspired by is that, from December until September, we have vaccines that are in clinical trials for COVID-19 already. That's amazing. It's taken less than a year to get something literally from bench top to arms, and I think that we will continue to build on that knowledge for COVID-19 as well as for RSV and influenza to keep getting better and better vaccines that are able to yield long-lasting immunity. One of the things about influenza, of course, is it changes every year, so we have to adjust the vaccine every year. RSV, when people get an infection, it seems that we stay immune for a time, but immunity wanes with RSV. So this might be one of those things where we have to get a new vaccine every so often, whether that's every year or every 5 years or every 10 years, that I think isn't known yet, but that's something that we'll uncover. And the same thing for COVID. It's going to be a while before we know exactly how to do this, and it might be that it takes us a few years to get that sorted, but won't that be a lovely thing to have to figure out, is how often do I give a successful vaccine? Thank you.
Great. Dr. Kim?
Yeah, I don't have much more to add to what Dr. Jump said. I think, what's made me wake up every morning, for the last 5 years working on adult RSV, is learning that and knowing that there are over 35 vaccine products in the clinical pipeline right now for RSV. That is a large number of products that the companies are trying. And for older adults, there are a couple that are pretty far along in the clinical pipeline. So I think even, phase 2B, potentially in phase 3. So, all the work that everyone is doing is just, that's the heartening part about it, particularly with RSV, and that's technically, what I work on at CDC. And I agree with everything Dr. Jump said about the COVID-19 vaccine and how rapidly, people have come together to get that into clinical trials so fast. It's kind of unheard of how quick it's happening. And I also think, what's heartening is having these webinars and having partners and people that are listening on right now that are truly interested in learning more about other respiratory viruses. Flu, we all know, go get your flu vaccine. Flu vaccine is becoming available. It's important to do that. That's an important thing to protect older adults this season. We don't have a vaccine yet for RSV, but when it comes, hopefully, again, the message will be, protect yourself, go get the RSV vaccine when it completes, phase 3 and is licensed for use. And the same for COVID-19. But yeah, the most optimistic thing that I have related is just the fact that vaccines are coming. And with those vaccines, hopefully we'll be able to prevent a lot of hospitalizations and a lot of mortality, and protect our older adults from these serious outcomes. Thanks.
Great. Thank you so much for all of these responses and all of the information and hope for the future that you've shared. On behalf of GSA and our speakers, I'd like to thank our participants very much for being here today. And thank you also to Johnson & Johnson Health Systems again for providing support for this program. Just a reminder that we are recording the session and we'll send you an access link by email once the recording is available. We don't have a lot of slides, but we do have some resources that we'll share soon. And you can download a copy of the presentation slides, including those resources, from the handout section on the right side of your screen. Before we move to the question and answer portion of this program, please know that a webinar survey will automatically launch after the webinar. And in an effort for continual improvement, we would love to hear your thoughts. Please provide feedback by clicking the survey link that pops up at the end of the webinar. So with that, we will move to questions and answers. Just a reminder that you can type and send your questions using the questions feature in the dashboard that's accessible on the right-hand side of your screen. We will not be using the raised hand feature today, so if you have a question, please be sure to use the questions panel. We will do our best to address as many questions as possible, time permitting. All right, we have a few coming in, so please continue to put your questions in that section. As those questions come in, I'd like to start with one for Robin. I'm wondering if there's anything we learned about infection control with COVID that did not work. In other words, is there anything that we can put aside as a mitigation strategy for respiratory illness this fall?
That's a really good question. I think what we know about infection control and prevention for COVID is that vigilance is important. We need the gowns and gloves when we're doing direct care, as well as the masks and face shields. And it seems that there's been a lot of evidence coming out fast and furious and going back and forth, but what seems to work best are face shields and masks, because it keeps us from touching our face and introducing fomites from the back of our gloved hand onto our face that later gets swept into a mucosal surface. And I'm drawing a blank on things that didn't work in terms of infection control and prevention.
It's good to know that what we have. It's good to know that what we have works. So
yeah. The other thing that people are doing is a lot more surface cleaning with wipes, and it's usually disinfecting wipes. It does not need to be bleach in the case of COVID-19, but disinfecting wipes, something that breaks down the envelope on that protein, or on the proteins on that on the envelope of the virus.
another question that we have is, at what point does it make sense to seek care for symptoms? Dr. Jump, do you have thoughts on that?
I do, and it depends a lot on the individual, but certainly if someone is having trouble breathing, increased shortness of breath, or they feel like they just can't quite take a good deep breath, that's a good time to go seek care. Other indications for care, and it's challenging in older adults. So for the older adult that lives independently at home. If they are feeling especially fatigued, body aches, can't get out of bed, I wouldn't wait on that either. If it's time to, if it's been a couple hours and things just aren't getting turned back around, it's time to ask for help, because the sooner that we get help, the often the less severe an infection can be. And I'm thinking here mostly about flu, because we know that the sooner we get medications for flu, the better people do. With some of the emergency use authorization medications that we have available for COVID, that may also be the case. There are, of course, not yet effective treatments for RSV, but supportive care is still a good thing to start doing early, and can help keep people from losing function. And that, of course, is a huge priority for us in the care of older adults. When I think about people in long-term care settings, these are folks that, if there's a concern for a respiratory virus, contact precautions, respiratory droplet precautions, transmission-based precautions need to happen right away. And even if if this is happening at 6 o'clock on a Friday night, the immediate response is to get the people into the appropriate transmission-based precautions, and then we can get the test the next morning if we need to. But it's important to take that immediate action first to protect everybody else in the facility. That's all that's coming to mind at this moment. Dr. Kim, do you have anything to add?
No, I think you've got most of the highlights there. Thanks.
We have a question that just came in. Are there any effective treatments for any specific viral pathogens?
Well, sure. We certainly have good treatments for influenza with oseltamivir. That's kind of the mainstay. And there's, I've forgotten the name of the drug already, but there's an inhaled influenza treatment as well. And that also seems to be effective, though oseltamivir is the one that I certainly have the most clinical experience with. And we use that both for treatment and for prophylaxis when there's a known influenza case in a nursing home facility. This works, and I can say that clinically. I can also say it personally. I had influenza a couple of years ago. I went to bed on a Wednesday night. My sweet husband went out and got me some oseltamivir, and by Friday I was Boy Scout camping with my 6-year-old, and it was a miracle as far as I'm concerned. So that one's fantastic. We don't yet have specific treatments that are directed towards COVID-19. Remdesivir seems to have a signal that's showing that it's helpful. The convalescent plasma seems to have some signal showing that it's helpful as well. And these both have emergency use authorization through the FDA. For RSV, there are not yet treatments that we can use specifically. That may change, and I think that the vaccine is probably going to be our biggest, our best effort there. And I think that one of the reasons perhaps why RSV treatment has not been it hasn't gotten the attention perhaps that it did, like influenza did, is because there has not been until recently good testing available for RSV. I think that one of the things that COVID has done for us is really emphasized rapid diagnostics, including for respiratory viruses. So now we can know quickly, does somebody have influenza or RSV or human metapneumovirus or COVID-19 or one of the myriad of other viruses that we have to worry about, and that can start direct treatment or supportive care. And it also helps us understand from a public health perspective the true burden of these diseases, and helps prioritize which disease should we start putting at the top of the list to try to get a specific treatment for. Thank you.
Thank you. Dr. Kim, is there anything you'd like to add to that?
Dr. Jump covered it. Again, for RSV, it's just supportive management. So, if a person needs oxygen, giving them supplementary oxygen. But she covered it very well.
Fantastic. So one last question. Knowing that we've got some experience behind us with influenza vaccine, are there lessons learned both in a long-term care setting and the community setting, some best practices that we can take and implement for an eventual, hopefully, RSV or COVID vaccine.
Sure. So this is Dr. Kim. I can talk about more in the community setting. I think Dr. Job can talk more about the long-term care facility setting. I think it's going to be, any vaccine introduction is going to require a lot of education. It requires acceptance by the community, by the general public. And so there's going to be a lot of education, communication that will need to be done for any vaccine, not just RSV when it comes out, but also for COVID. And I think that's going to be the biggest important thing, because even if we get a vaccine and the clinical trials show it works, if the community or if the public doesn't understand why they should get the vaccine or feels like it won't work, then it won't work, because we won't be able to have as many people that need to be vaccinated to get it, right? So I think the biggest challenge, something that we learn is from an early start when we hear about vaccines, is to go ahead and engage with as many stakeholders as possible. So this is one of the, AGS is one of our stakeholders, clinicians, stakeholders, getting as many people, getting their input, about how to target the vaccine, how to communicate what a vaccine is, why it's going to be helpful for you. That's incredibly important. And I think that's something that underscores everything. We have to be transparent, we have to be clear, and we have to show why it is important for everyone to get a vaccine, depending on what target group it is. And so that, to me, is a big issue and a big lesson that we can learn. It's always a challenge with flu. We know adults have far worse vaccine coverage and immunization rates as compared to children. It's education. It's educating those older adults, educating their doctors, their nurse practitioners, the clinicians who will actually give them, the nurses who will give them those vaccines. If we have those, everyone who cares for an older adult, in some ways needs to be a champion of vaccines. So we can't forget that at every encounter that we have. So I think the challenge is always going to be, clear communication and an adequate campaign strategy, communication campaign strategy for vaccines. Thanks.
So that was excellent. And I agree wholeheartedly. Getting people to accept the vaccine is so important. And I just thinking in terms of some of the more pragmatic ways that we can do that. We know that for influenza, that even if the vaccine that we have for a given season is not a great match, it still helps. It still helps mitigate the symptoms and the severity of disease. So what I tell people is, it's a poke in your arm and it hurts, and you might feel a little bit uncomfortable the day after, but that's so much better than getting the flu. And the other thing that I tell them regarding influenza vaccine is that it also helps mitigate the risk of diseases down the road of influenza, that maybe it's not a great match this year, but maybe it'll be a good match for the viral strain that's going to come out in 3 years, in which case you've already got the antibodies and you're protected, which is a great thing. So that message of I think that the benefit or the potential benefit of vaccines is important. We're just getting to hear some information about how COVID-19 might mutate, and letting people know that there's a need to probably get more than one vaccine at some point is okay. And just, don't wait for the perfect one. Just do what you can now to protect yourself and everybody else in the community. And that's going to be the same for RSV. Part of the reason why people are so emphasizing influenza vaccine this year is to prevent that respiratory illness on top of COVID-19. And when we have an RSV vaccine, we're going to need to be able to do that same thing. Protect yourself from everything that you can. Some more pragmatic things to do to help with this is that we have to get our staff to accept the vaccine too. And I feel like most healthcare workers accept their influenza vaccine, do it, no big deal. It's for their own health, for their family's health, and for the health of the people for whom they care. Long-term care is the worst in terms of healthcare sites about the coverage of vaccines among, the staff getting the vaccine. I don't know the reasons for this. I know that hospitals have had great success with making vaccines for employees mandatory, and I think that that's something that we should be doing in long-term care as well. And in fact, I support the American Medical Directors Association. There's the Society of Post-Acute and Long-Term Care's statement about making it mandatory for long-term care employees to get an influenza vaccine. Something that we can all do when the vaccine becomes available is make sure that we model to our other staff members that we're getting it, and also to offer it to our employees, or have our health systems offer it to our employees, and to do that on all shifts. And that can be done by catching that 3 or 4 o'clock shift and making sure that there's someone there to get the vaccine then, and also by having someone come in early to get the vaccine at the end of the night shift, so that we get as many needles into arms as we can. Thank you.
Thank you. Thank you both for your wealth of knowledge and for sharing it with us today. We've covered wide amount of information, wide ground, and I hope that our participants found the information as helpful as I did. So we have a couple of slides with some resources on them. I would encourage you to download the handouts. We have these slides posted in the handouts so that you'll have access to both GSA resources and some of our partner resources that have specific information about COVID-19 as well as RSV that we think you may find helpful. So please download those handouts. Again, we'll have this posted for you to share with colleagues, the recorded version, and you'll get a notification of that once we have that up and running. We appreciate all of you being here today. We appreciate your participation, and that concludes our program for today.